Hello everybody, this is Dr. Eyas Alkhalili. You can call me always Dr. A. I'm the lead surgeon for the Robotic Thyroid Surgery program at the Clayman Thyroid Center and the Hospital for Endocrine Surgery. And we are here to talk about thyroid care and thyroid surgery. So, welcome. So, going to be taking questions. So I have a few questions here. So here, I've been told I have thyroid nodules. How do I know if there's something to worry about? All right, so that's a very good question. So thyroid nodules are almost always discovered incidentally, meaning without having any symptoms. For the vast majority of time, about 95% or so, these nodules constitute benign disease. However, if you notice that you are having symptoms such as pressure in the neck or trouble swallowing, then that can point to large or symptomatic nodules that need to be addressed surgically. In addition, the best way to know if thyroid nodules are suspicious or require any surgical management is to perform neck ultrasounds. These exams are radiation-free and they're affordable and very quick to perform and provide great accuracy in terms of determining the risk of cancer in thyroid nodules. Another question here is how common is thyroid cancer, particularly in women? So I think we are estimating that in the US we're going to have about 44,000 new cases of thyroid cancer in 2025. Overall, it's, I think, right now the 8th most common type of cancer. Women outnumber men 3 to 1 for reasons that we don't quite understand very well. However, despite the rising incidence in thyroid cancer, the prognosis is still very, very good. In fact, it's excellent with over 96% of patients alive at 5 years after the diagnosis. The next question I have here is what kinds of tests are done to figure out if a nodule is cancerous? And how often do they turn out to be cancerous? All right, so I partially already answered that question previously by talking about the initial step, which is after physical examination, is thyroid ultrasound. Thyroid ultrasound can determine the cancer risk in thyroid nodules, provide an estimate. The next step would be fine needle aspiration biopsy, meaning the aspiration of cells from the thyroid nodule and examine it microscopically to see if we can have an answer. Now, in about 95% of the time, thyroid nodules are actually benign. However, sometimes the thyroid biopsies can be indeterminate. I'm sure that's something we can talk about later on. So while thyroid FNA is very helpful in determining thyroid cancer risk, it's not always 100% guarantee that we're going to get a definitive answer with that biopsy. And as such, sometimes we have to resort to surgery. The next question I have here is if my biopsy came back indeterminate, what does that actually mean and what happens next? So that's a very, very good question, and I get that asked quite a lot actually by patients. So it's in order to answer that question, I would like to first explain how do we perform FNA or fine needle aspiration biopsy. So the needle we use to biopsy thyroid nodules is very, very small. And what's called the aspirate or the collection that we have during the biopsy contains cells as opposed to structured tissue, which we do for other organs biopsies. Now, these cells, once they put under the microscope, are analyzed and they would fit into one of 6 diagnostic categories, ranging from we don't have enough cells, we can't make a diagnosis, all the way to cancer diagnosis. However, things are not always black or white, and somewhere it's along that spectrum, there is that gray, indeterminate category of diagnosis. We call them Bethesda categories 3 and 4. What that means is that you get an estimate for cancer risk, and usually that means that the next step either be more sophisticated testing or diagnostic surgery. The next question I have here is, how do I know if I'm a candidate for robotic surgery? So that's a great question. As many of you know, robotic thyroid surgery is not commonly performed in the US, so there are very few kind of centers of expertise performing that surgery. We are by far the largest volume center in the United States, and probably just lagging behind the big centers in Korea in terms of volume. We don't have absolutes when it comes to candidates for robotic surgery. The vast majority of patients are eligible candidates, meaning we're able to safely perform the operation with the assistance of the robot. The very few exceptions would be patients with very large and advanced thyroid cancers, such as the more aggressive forms of thyroid cancer, which are the non-differentiated thyroid cancers, very large goiters with extension into the chest, and then some patient factors, such as if the patient, we cannot position them in a certain way that we need to perform the robotic surgery. But for the vast majority of patients, regardless of age, sex, initial diagnosis, whether it be benign or cancerous or inflammatory thyroid disease, most patients are candidate for that. The next question I have here is, how fast does thyroid cancer usually grow, and do I need to rush into surgery? So that's also a very good question. So there is no absolute number that I can actually quote and tell you if a thyroid cancer would grow or not. We know that the vast majority of thyroid cancers are, for lack of a better word, indolent, and they grow slowly. However, we also know that there are outliers, such as more aggressive forms of thyroid cancer that grow very fast and tend to spread as well. There is no way for us to actually predict the natural history by which the thyroid cancer would behave. And as such, I would say, while the surgery is not an emergency, it's not something that needs to be done within a week or so. It is definitely still a surgery that needs to be done within a reasonable time frame, whether it be within a month or 2 months or so. It's not something I would push off for years, for example. I get asked that question all the time, if I can delay my surgery for 6 months or so. And most of us thyroid surgeons would feel uncomfortable waiting that long for surgery for thyroid cancer. And the next one is actually connected to the question before, is thyroid cancer usually curable? And what's the typical outlook after treatment? So the answer is yes. For the vast majority of cases, it is curable. If we talk about cases at presentation, for the early stage cases, once appropriately treated, we're looking at about 95 to 98% chances of cure. And after surgery, most patients don't require any further treatments. For example, question I get asked a lot is, am I going to require chemotherapy or radiation therapy? And the answer is almost always never. It's very, very rare types of very aggressive thyroid cancer who are fortunately very rare that we use those treatment modalities for. And the most common treatment modality that's done after surgery is in the form of radioactive iodine. All right, the next question I have here is, can thyroid cancer spread to other parts of the body? If so, how often does that happen? So, very, very good question. So it is extremely uncommon for thyroid cancer to spread outside the neck. So there's a difference in terms of the extent of spread, whether it be because the first stage of spread is metastatic spread to the lymph nodes in the neck. And while that is very common, we know that actually doesn't affect staging of the disease. It has very minimal effect on the overall prognosis. Spread to other parts of the body, meaning other organs such as the bone, the lungs, brain, etc., is fortunately not common at all. It's about 4 to 5% only of all incomers. Now, when that happens, in the case of well-differentiated thyroid cancer, the most common form of thyroid cancer, which is papillary and follicular, it's actually still curable because that disease responds very well to the treatment with radioactive iodine. So while it is, a more advanced stage and less favorable prognosis, it's still manageable. If I need surgery, how do I know if I should have my whole thyroid removed or just part of it? That's a great question. So, as many of you probably heard, in the past 10 years, the treatment for thyroid cancer has shifted from being over-aggressive, for lack of a better word, I think, into performing the minimal amount required to cure patients and minimize the complications and the morbidity of the treatment. What that means is that for small cancers, we are able to cure the disease by removing half the thyroid gland as opposed to removal of the entire thyroid gland. The decision about whether we have to remove half or the whole depends on multiple factors. One of them is the stage of the disease. If the disease has spread, for example, to the other side of the thyroid, if it has spread to the lymph nodes of the neck, that means probably we're best served with removal of the whole thyroid. The patient preference is a very important factor here because some patients prefer to have the more conservative and have their entire thyroid removed, while other patients prefer to preserve thyroid function, which means we have to try to preserve as much thyroid tissue as possible, in which case we would remove half the thyroid only. Other factors include if the patient has thyroid nodules that are symptomatic or not on both sides of the thyroid versus one side, and also if there's thyroid dysfunction, whether it be hypothyroidism or low functioning thyroid, or hyperthyroidism or overactive thyroid. And those conditions, for example, would require removal of the entire thyroid gland. Will I need to take medication forever if my thyroid is removed? So the short answer to that is it depends on the extent of the surgery. And if we are talking about removal of the entire thyroid gland, then the answer is yes. Because once we remove the entire thyroid gland, there is no source of thyroid hormones, the hormones that regulate our metabolism. And as such, when we do a total thyroidectomy, full removal of the thyroid gland, then we start the medication the very next day after surgery. When we remove part of the thyroid, half the thyroid, for example, not all patients require that treatment. It depends on the studies you look at, but if we're talking long term, it's somewhere about the 20 to 40% risk. And that's requiring the medicine over years after surgery, not immediately afterwards. In any case, whether we end up removing the entire thyroid and placing patients on thyroid hormone replacement pill immediately after surgery, or when we do partial thyroidectomy and we don't, we always recommend testing thyroid hormone levels about 4 to 6 weeks after surgery. Will my quality of life ever be the same after having my thyroid removed? What is the recovery like? Very good question. So the short answer is no. The quality of life will not be affected for the vast majority of patients. In fact, some patients who have thyroid dysfunction, such as Hashimoto's thyroiditis or hypothyroidism or Graves' disease and hyperthyroidism will feel better after thyroid is removed, because the quality of life is actually one of the indications for us to perform surgery in those patients. The recovery leg is actually easier than most other operations. So it's nothing like, say, a colon surgery or a kidney surgery or lung surgery. Nowadays, the vast majority of our cases are done on outpatient basis, meaning most patients are able to leave the hospital the same day. They are able to resume their diets immediately afterwards. They are caring for themselves, up walking and talking the very same day. From a type of surgery that is performed, sometimes we see differences in quality of life. For example, young patients who get traditional thyroid surgery feel very conscious about having scars on their neck because it's very visible. And we know that can affect their quality of life, and those patients actually do a lot better when the surgery is done via a hidden scar robotic approach, as the literature shows. Okay, the next question I have here is, what questions should I be asking when choosing a thyroid surgeon? Great question. One is, before you ask your surgeon, is to check your surgeon's credentials to know if they are specialized thyroid surgeons or not. The vast majority of thyroid surgery in the United States nowadays is unfortunately performed by low volume surgeons. And while for lots of the time the outcomes are actually acceptable, we know from the literature, without a doubt, that high volume surgeons have much better outcomes than low volume surgeons. So, for example, you can tell if a surgeon is actually specialized by their advanced training, if they performed advanced training to take care of thyroid patients and perform thyroid surgery. One of the questions you may want to ask to your surgeon or to other patients in the community or their office is that, what is their volume when it comes to thyroid surgery? How many thyroidectomies do they perform on a yearly basis, for example? Anything usually lower than 100 cases a year is considered low volume. But it depends on which society guidelines you're looking at. But the bottom line is you want to look at a high volume surgeon and a surgeon with a record of good outcomes. All right. The next one I have is, I've heard robotic thyroid surgery leaves no scar on the neck. How does that work? Where are the incisions made if they're not on the neck? So, very good question. So, there are multiple ways to perform what we call remote access or scarless thyroid surgery. The two most common that are performed nowadays are via transaxillary or incision placed at the edge of the armpit, which is our preferred approach here at the Clayman Thyroid Center. There's also the transoral approach, where the incisions are placed inside and behind the lower lip. In both cases, patients do not have any visible scarring. So in the case of transoral approach, because the incision is made through the lips, there's no incision actually made on any skin. It's just the mucosal surface of the mouth. That approach has some additional risks on top of traditional surgery risk. And then the transaxillary incision, or placing the incision in the armpit, is placed in a way that the incision is not visible at all, because we actually design the incision while the patient is awake, before going to sleep, to ensure that it won't be visible, even if, say, for example, they're in the beach, it's not in an area that is actually exposed. How does that work? The short answer is with the assistance of the robot, because once we make the incision remote or away from the thyroid, that means we are not able to reach the thyroid with our bare hands. For example, when we place an incision in the armpit, you can imagine that we have to, for lack of a better word, walk the distance between the armpit and the neck to reach the thyroid. And that's performed by creating a small, tiny tunnel underneath the skin over the collarbone. And then to perform the operation, that's where the robot helps us do it, because as opposed to my fingers and my arms, the arms of the robot are 6 millimeters each. That's half the size of my smallest finger, and that means I would be able to do the surgery with minimal dissection, very minimal amount of inflammation and swelling and pain post-operatively. And the other advantage is that because the instruments are so delicate, they actually help us preserve the vital structures around the thyroid, mainly the nerve to the voice box and the parathyroid glands. The glands control the level of our calcium, so we handle them with very great precision. Next question is, what does single port robotic thyroid surgery mean? So, single port is the latest robotic platform that was developed for performance of surgery in tight spaces. And single port means that all the arms of the robot, the 3 arms that we use for the surgery, as well as the eyes of the robot or the camera, are passed through a single cylindrical port. Then the size of it is about 1 inch only. And that is a great breakthrough, because in the old days, we had to separate the arms of the robot in a way that prevented us from performing the surgery in tight spaces very well. So previously we had to make excessive amounts of dissection, which meant more inflammation, more pain, more discomfort, and just surgery taking longer to be able to accommodate the robot into that surgical space, because it couldn't fit in such a tight space. But the single port, because of its size, now we're able to make a very small 3 to 4 centimeter incisions, for example, in the case of the thyroid, which are half the size of the incisions used for traditional surgery, to be able to perform the operation. That also means we are performing less dissection, we're spending less time under anesthesia, we have less pain, less discomfort, and more speedier recovery really for most patients, which is great. Okay, the next question I have, what are the biggest advantages of robotic surgery? So there are 2 groups of, I would say, in terms of advantages. Advantages to the patients, or directly, I would say, to patients, and then advantages to patients that come indirectly because they benefit the surgeon. So let's talk about the benefits to the patients first. So at the very top, the most obvious is cosmesis, because when we perform remote access robotic thyroid surgery, there are no visible scars, meaning the patients don't have to worry about their appearance at all. They don't have to worry about hiding the scars or whatever, and that affects their overall quality of life. Also, when it comes to performing robotic surgery, we are able to preserve as much as possible of muscle tissue of the neck, which means very good recovery, minimal inflammation, and minimal pain. Now, there are also indirect benefits to the patient that comes through the benefits to the operating surgeon, because the surgeon has advantages of performing the surgery robotically. One of them, for example, is the robot eliminates tremor, which is a very human thing, right? We all have a certain degree of tremor depending on how much caffeine we've had, et cetera, et cetera. So even surgeons have it. However, the robot doesn't tremor at all. The second advantage is the robot allows for you to scale your movements. So for example, my movement outside the body can be scaled down to a ratio of 3, so that when I move my finger outside by 1 centimeter, the robot will move on the inside by only 3 millimeters. that allows me to do more precise movements on delicate structures, such as the nerve to the voice box. The other advantage for the surgeon is that you are looking straight at the surgical field in 3D view, and you're not distracted by anything else. When we do open surgery, we have to do certain things to be able to see the surgical field very well, such as wearing magnifying loupes, wearing certain form of light source to be able to see through the small incision we create on the neck, and to see those very small critical structures, the nerve, the parathyroid glands, etc. The robot eliminates all of that because it does all of that for us. The robot will illuminate the field with LED lights. It has 3D dimensional image. The robot also allows the surgeon to sit down when they're operating, look at the surgical field, for lack of a better word, in virtual reality, basically, and they're not distracted by anything else happening to the sides. So they're quite literally immersed in the surgical field. And that means 100% full attention on the operation they're doing. And obviously, while these are advantages to the operating surgeon, I think these would spill over as benefits to the patient, because the better I can perform the operation, that means the better the outcomes are for my patients. Does robotic surgery take longer or cost more than regular thyroid surgery? The short answer is no. To the patient, there is no difference in terms of the cost when it comes to thyroid surgery. Patients are not charged more for robotic thyroid surgery, and insurance covers robotic thyroid surgery just like they do with traditional thyroid surgery. The surgery itself doesn't take longer in the hands of highly experienced surgeons. So, for example, we, as I mentioned, perform more robotic thyroid surgery than anywhere else in the country. So we do this operation quite frequently and very, very well. And most of our patients, the surgery takes about 35 to 45 minutes, for example, if we're just removing half the thyroid, which is, if you compare it to the average community or the average thyroid surgeon outside the Clayman Center, that's actually faster than traditional thyroid surgery. So the short answer is no, it doesn't cost more and it doesn't take longer to perform. The next question I have is, can you also address the lymph nodes during a robotic operation? Yes. The short answer is yes, because as I mentioned before, our visualization of the surgical field is sublime, honestly. So everything we could do in traditional surgery with an open approach is done similarly with the robotic surgical approach. We are able to perform lymph node sampling, full neck dissections. In fact, in very good candidates, we are able to perform the full extent of neck dissection for advanced thyroid cancer robotically. And the literature overall shows that, including our own series, that the amount of lymph node tissue that's removed during robotic surgery is as good, if not actually better, than open surgery for certain cases. So yes. Is robotic thyroid surgery just as safe as traditional surgery? The short answer is yes. The caveat to that is you want to make sure that if your surgeon is offering you that option, and I know there's very few surgeons in the US who do robotic thyroid surgery, they are actually high volume surgeons and they have a well-established record of good outcomes. There is no literature out there to suggest that the outcomes are by any means are inferior in when selected patients. All right, and I think time is up. That was our last question, but stay tuned. Hopefully we'll be back next month with more sessions. Until then, take care.